Thank you. Good afternoon, ladies and gentlemen. Why don't we get started? I'd like to welcome you to the Woodrow Wilson Center. My name is Jeff DeBelko. I have the good fortune of directing our environmental change and security program, coordinating our global health initiative here. And so it's a tremendous pleasure to welcome some new friends to the center and some old friends back to the center for a discussion we've entitled New Insights into the Population Growth Factor in Development, another collaboration for us with Venture Strategies, and it's terrific to welcome Martha and Malcolm back to the center for what, again, promises to be another fascinating session. As I said, we've had the good fortune to collaborate with them before. A word about where we're sitting. The Wilson Center is actually the formal memorial to Wilson, and apologies to friends who've heard me say this many times before, but Wilson is our only president to have had a PhD. And so when Congress set up a nonpartisan, non-advocacy forum, they decided, instead of building an obelisk on the mall, to have a living memorial where these worlds of scholarship and the worlds of policy and practice could come together and learn from one another. So we have, as a center, been doing that since 1968, our particular program since 1994, and for our program, really trying to bring together some issues that aren't always in the room together, in communities that don't always have a lot of places to talk, population, health, environment, development, foreign policy, and even at times security policy. So this is what we try to do with a range of meetings, such as today's, publications, and I hope you will pick up some of the ones outside that are really aimed at trying to look at how these issues are integrated both in analytically but also in the on the ground in terms of how we respond to them. I think today's discussion will be tremendously helpful in bringing forward kind of data-rich and research-rich analysis and having that inform our policy questions and our policy decisions. And so it was terrific when Martha and I and colleagues started talking about this, and some various occasions to have some new friends visit the center. We leapt at the opportunity to do that and to hear to get outside the Beltway in terms of our conversations, avoid the echo chamber effect that too often we have in this town, and have this larger discussion. I'm going to turn the floor over in a moment to Martha to kind of set the stage and introduce our panel. But I'll say just two more quick announcements. One, want to thank USAID's Office of Population and Reproductive Health for the long-term support they have provided to us to make these kinds of meetings possible. We're very pleased to be at the beginning of a new collaboration, a new agreement that we've called HELPS, Health, Environment, Livelihoods, Population, and Security. Again, reflecting, bringing all these things together. And so it's terrific to see Jeff and Heather and Liz and some folks from that office here today. And then finally, just to say that we're webcasting today's event live, as we try to do with so many of our meetings, so that this discussion can go beyond this room. What that means for us in the room is when it comes to the Q&A time, just could you wait for one of my colleagues to bring you a microphone and state your name and question so the folks online can hear it. For those of you online, what it means is the PDFs of our presentations are available there on the web page, and particularly if you send in a question early within the time to ecsp@wilsoncenter.org, we'll try to get that question into the discussion as well. So Martha, I'd like to turn the floor over to you. Martha, I think as many of you know, is President of Venture Strategies for Health and Development, someone who has long been deeply involved in both the research and the practice side of this, and it's a pleasure yet once again to be working with her and her colleagues from Venture Strategies.
Thank you very much, Jeff. It's a great pleasure to be back here again. I just want to mention that I teach at Berkeley as a lecturer in the School of Public Health, and was heading the population program in the David and Lucille Packard Foundation in the 1990s, and then started Venture Strategies for Health and Development, a nonprofit working a lot on maternal health issues in low-resource settings, but also really keenly interested in the population growth effect on development and on health, and something we worry about a lot. The subject of population growth has been around for a long time, but it's been pretty silent among a lot of people and the media, especially in the last 15 years, which means people can't learn about it if the language of population growth and the language of family planning haven't been really open to the public. We consider these very important because there are a lot of things that can't get done without that. We have not found, for example, any country that has developed or gotten out of poverty while maintaining high birth rates. We can't find any. And that's some kind of a clue right there as to the relationships. And we can get into that, I hope, later in discussion. And I think there will be a lot of discussion and time for it later. We have some very special people here today who are experts, both African, one a demographer, one a physician, and who have special interest in clarifying for policymakers with the information that they need. There's a lot of good research out there, but trying to pull together what the priorities are on the basis of just clarity and translation of how you can turn this into practical use for decision makers is very important. I would like to first introduce Dr. Eliya Zulu, who is a premier demographer in Africa, and who is the elected director of UAPS. UAPS is the Union for African Population Studies, which has at least 1,000 demographers in it in Africa, and it's a 4-year post. And he also has been the person who founded AFIDEP, the new African Institute for Policy Studies, exactly to do the transition or translation, if you will, to from the research into policy language for decision makers, for policy makers throughout Africa. It's a very, very interesting concept, and it's exciting to see the kind of work that they are doing. I think we'll just turn this over to Dr. He's from Malawi, by the way, and his degrees are from the University of Pennsylvania, his PhD, and earlier degrees, in fact, from Australia. But let me turn this over now to Dr. Zulu. Thank you.
All right. Thanks a lot, Martha. And I don't know whether it's still afternoon or evening, but good afternoon, everybody. So my presentation, this is basically the outline of my presentation. What I'm going to talk about is just what are seen to be the population challenges in Africa and the framing of these issues. And I'll present quite a bit of data and go through those data slides quite quickly, but the main aim is really just to illustrate how these issues are framing the discussions on population in Africa. And then my colleague, Dr. Musinguzi, will come to also, give more insights on those issues. You've probably all seen this chart basically just showing how the global population is growing. The projected population, according to the UN projections, that the global population, which is about 7 billion now, will increase to 9.2 billion by 2050. But I think what's clear is that most of this growth will be generated in the less developed world, where most in the least developed countries, where most African countries actually fall. Africa is projected that its 1 billion population will actually increase to 2 billion by 2050. And I think another key point to note there is that the share of Africa's population in the global global size will increase from the current 15% to 23% by then. Those sorts of numbers, actually, when you look at them, the UN projections, that was the medium variant. That is, the assumption that if we follow what is like the middle level sort of fertility, that's the figure I was giving you. But what this is illustrating is that actually Africa's population of 1 billion can reach between 1.8 and 2.3 billion by 2050, depending on how well the continent actually does in reducing fertility. This gap, which is about 600 million, actually represents Africa's total population barely 20 years ago. So while we often take it that it's the medium variant, maybe we tend to just think about the middle ground and so on. If you look at the table below, which shows the fertility assumptions, currently the total fertility rate in Africa being 4.7, you can see that the difference actually between the highest fertility and the lowest fertility variance is just one child. So so it's very, very easy to see how the if really the efforts to reduce fertility are not intensified, it's easy to see how we can actually go to the end part where we end up with 2.2 billion people as opposed to the 2 billion that we are talking about. The point of this table here is to note that while the continent as a whole has a big population growth challenge, there are actually big differentials within the continent itself. The rapid growth is mostly driven by West, Central, and East Africa, with Southern Africa and the northern part of Africa actually not growing as fast. When you look at these figures, one may ask, so what? Other people have argued that actually big populations may be good for development, or it's a politically sensitive issue. Some countries feel, that they are strong when they have big populations. So why should we be worried about this? The truth is that while big populations may actually be good for by providing, a big labor force, economies of scale, and so on, rapid population growth makes it harder for governments to provide the basic social services that are needed to improve the quality and productivity of their populations. And that these challenges are actually even bigger in the African context, where economies have either stagnated or are growing have been growing very, very slowly over the last two decades or so. And we also have to think about the consequences of having such big populations for the continent's rapidly deteriorating biodiversity. The primary means through which populations have reduced their fertility and population growth is through mass adoption of modern methods of family planning. In 2008, 55% of married women globally were using modern contraception, but only 17% were doing so in sub-Saharan Africa. In West and Middle Africa, actually only 10% were using modern contraception and 7% respectively. So East Africa has, a relatively high sort of contraceptive use rate, but the fertility is still high, suggesting that, most of this use is actually for spacing as opposed to limiting the number of children that women should have. So you can ask the question, why are people having so many children? But before I get to that, I'll just quickly go through some other issues relating to the population growth factor. And here the main focus is on the issue of urbanization. In 2008, as many of us here may know, for the first time in human history, the world's population became more urban than rural. This figure shows that developing countries, actually, we're saying that most of the growth in population will happen in developing countries, but it's critical to note that even within the developing countries, most of this growth will be happening in urban areas. In Africa, the tipping point for what is called the urban tipping point is projected to take place around 2032, after which all the rural population will stabilize and start declining, while most of the growth we are talking about will actually be happening in urban areas. So why should we be concerned about this rapid population growth, which is really pushing also rapid urbanization? The truth is that the consequences of urban rapid urbanization, which is taking place, the consequence of Africa's rapid urbanization growth, which is taking place amidst economic stagnation, also I think we have to accept it's not just rapid urbanization and so on. There are also issues of governance. There are issues of planning that, we need to plan our cities better and so on. But as a result of this, a combination of these factors, there's a rapid growth of slum settlements in Africa and other developing parts of the world. These slum settlements are characterized by poor housing conditions, poor social services, non-existence of basic amenities in some cases, poor health outcomes, insecurity, unstable incomes and livelihoods, and so on. But so if you look at the green chart there, it may give you the impression that there's been some progress in Africa in reducing the prevalence of the number of people living in urban slums. But the red chart actually shows that the number actually doubled between 1990 and 2010. And UN Habitat estimates that by 2020, there will be 372 million Africans who will be living in slum settlements. And another point to note, I think when we talk about urban growth, rapid urban growth, people tend to think that it's because it's largely generated by rural to urban migration. But this slide here shows that it's actually the natural increase, the fertility within urban areas themselves that accounts for most of this growth. In developing countries, it's 60%, but in Africa, because of the high fertility that we see even in urban areas, 75% of the growth is actually due to that. I mean, this chart here is just emphasizing the same point, that sometimes we tend to think, oh, urban areas are better off because there are hospitals there, the facilities are better, but that in urban areas, when you start looking at the poor versus non-poor, there are very, very high levels of unwanted fertility even within the urban areas, as you can see in these, the example from these three cities. Apart from urbanization, another critical demographic sort of a feature of Africa is the young age structure of the population. And this is driven mostly by high fertility over a long period of time. And what you see here is that between 40% and 50% of the populations in East and Southern and West Africa are below 15 years of age. And between 30 to 40% are actually between 10 and 24 years. What are some of the implications? There's a very, very high dependency ratio. We need to talk about building the Africa of the future. We need to think about how we can have, how we can improve education, how we can protect the young people today, their sexual needs, and so on. But with such a young population, it's very, very hard for us to actually achieve these objectives. But another critical component that is related to population growth, another critical component or implication of a young age structure is actually that it produces high momentum for further population growth. And this chart here illustrates how a young population has inbuilt momentum to continue growing for many years, even after the population reaches replacement level fertility, which is estimated to be a total fertility of 2.1. That is, a woman is actually producing enough children just to replace the current generation in future. So this is Ethiopia, the third. Sometimes people say it's the second, but the third largest country in Africa. So this is very significant. And what it shows is that even if Ethiopia's total fertility reaches 2.1 in 2020, for instance, which is 10 years from now, its current population of 95 million will continue growing for another 50 years and stabilize at about 110 million in about 2070. However, if replacement level fertility is actually attained, say, 20 years later in 2060, which seems, not very unrealistic when you look at the assumptions that we looked at before, the population would then stabilize at 300 million, and that stabilization will happen in the year 2110. So again, this shows the urgency of trying to address the issue of population. This brings in Zimbabwe. And the main difference between Zimbabwe and Ethiopia is that Zimbabwe has a lower fertility level, and the population is is less younger than the one for Ethiopia. So the differences across the three scenarios are not that big, but the momentum is still there because the population will still grow for many years to come and stabilize after 40, 50, 60 years. And finally, I would like to look at this other demographic feature also. I think that those who have looked at development among the Asian tigers, we've noted how this demographic dividend actually helped the Asian countries to actually get away from the sort of developing country to middle income sort of status. So as fertility is declining and mortality is declining, the dependency ratio goes down, and that allows a country to actually release resources for investment in the current labor force, but also investing in the quality of the population through better education and so on. So this is like Kenya. In 2010, 55% of the population were in the labor force, while 43% are in the youth age group. If fertility continues to decline the way it's projected now, in 2030, 61% of Kenya's population will be in the labor force. And in 2050, 65% of the labor force, the structure will change. So this is just part of the demographic process itself. It's not something that anybody is doing anything about to engineer it. But as fertility and mortality declines, the age structure changes such that you get this so-called demographic dividend, where now you are able to have a much bigger labor force. So the point we need to ask ourselves is Africa ready to take advantage of this? Because this process is on the way. Analysis of the Asian experience by the World Bank experts showed that for a population to take advantage of this, the labor force itself has to be well educated. It has to be productively employed, so the economy has to be able to generate enough jobs. And if those two conditions are met, then you'll be able to make the savings and investments that are required. So the point I want to make here is that when we talk about fertility, reduction of fertility or controlling population growth, it should not just be about reducing fertility. We should also be thinking about how we can invest in the quality of the population so that when this dividend comes up in Africa, Africa can take advantage of it. And I think I've gone through the data there. Now I want to get into this issue. One, I think, can ask the question, okay, if you look at all these population growth challenges in Africa, why is it that people are not actually having fewer children in Africa? It's the only continent where fertility is still so high. And yes, it's true that large families are quite highly valued in many parts of Africa, yes? However, the evidence in this chart from the work that the Guttmacher Institute and UNFPA did recently shows that a sizable proportion of women in Africa would like to control their reproduction. Actually, 78 million of them, but only 40% of them, of the women who want to avoid pregnancy, were actually using modern contraception. In 2008, 47 million, which represents the 60% of those who wanted actually to control their fertility, were not able to do so because of lack of contraception or lack of access and many other reasons. And if you look at, that's looking at those who are not using family planning, but you can also look at those who already have a child and ask them, did you want to have this child, and so on. So that's looking at the unintended pregnancies. This work shows that 17 million of the pregnancies were actually not intended. And 91% of them were either not using contraception or using largely ineffective traditional methods. So, from where I stand, it's very, very clear that Africa has very, very high demand for fertility control, and that the demand will undoubtedly increase in as many parts of the continent where people still desire many children revise their fertility preferences. The main challenge, therefore, is not that of demand, but how to ensure that those who are in need actually have access to contraception. And I think if you can just focus on that, even without talking about the issue about population control and so on, we can actually reduce the level of fertility in Africa substantially. When you ask those who are not using contraception why are not using contraception, these are the sort of reasons you get. There's still quite substantial opposition to family planning, as you can see in the numbers that are highlighted with red. But there's also quite substantial proportion of women who are not using family planning because of what are called method-related reasons. And most of these reasons are actually related to the health concerns that women have about family planning. So these are the sort of issues that family planning programs can address by improving the quality of services, by making sure that services reach out to people where people are as much as possible. But I think the truth is that family planning, for family planning programs to be used sustainably in Africa, they have to be heavily subsidized or given free of charge, because studies have shown that 97% of the women cannot afford the full cost of contraception. Which gets to this slide about also the work that the Guttmacher Institute and UNFPA did recently. And this slide actually shows the extent of the funding gap in meeting the unmet need for family planning. But it also provides what I consider to be a very strong case for investing in family planning, maternal health and newborn health services. According to this analysis, the annual investment in family planning, if the annual investment increased from the 290 million to 2.3 billion in Africa to erase basically all the unmet need for family planning, these are the sort of effects that would have, that you would reduce unintended pregnancies from the 11.7 million to about 2.7 million. Induced abortions will reduce from about 3.5 to 1.2 million. And the reductions in maternal health are also there. So this is basically the situation in Africa. But very quickly, I just wanted to say, I think while in the past there was some tension, there was some debate about really addressing population issues in Africa, right now the landscape has changed a great deal. And the big advantage that we have on the continent now is that there are many countries that have shown that with seriousness, with proper leadership, strong government leadership and so on, you can address a lot of these population challenges. I'll just go through a couple of them here. I think we all know about Kenya, which in 1978 had the highest fertility level in the world. But this fertility has reduced to 4.6 by now. Total use of modern contraception has gone up from 4% to 39%. And this was mostly because of providing an enabling environment that allowed a lot of international players to come into the country, and also the issue of political leadership, strong political leadership. We should also mention that Kenya and Zimbabwe, which is the next country, also invested a lot in the status of women. These two countries have the highest levels of female literacy around the continent and so on. But Zimbabwe is another country that is there. But unlikely what I'm calling emerging success stories. You can look at Malawi, for instance. Malawi banned family planning in 1969. It was only reopened in 1984. But within this period, although the total fertility is still very high, Malawi has managed to increase contraceptive use of modern methods from 1% in 1984 to 28% in 2004. Ghana is another, success country, another country that you can look at. Proper leadership, commitment to addressing population issues. And I think one of the countries that I should also mention quickly is Rwanda. With the genocide, people would have thought that the country wouldn't want to be worried about these issues. But in a period of 3 years between 2005 and 2008, use of modern contraception increased from 10 to 27%. So what are the key messages from the issues that I'm raising? Yeah, Africa's, the key sort of population challenges in Africa are still rapid population growth. The young age structure, it poses a lot of challenges for development. But I think the issue of rapid urbanization and its consequences also has to be looked at. Addressing these concerns is increasingly seen to be, however, sorry, I think I went. Addressing these concerns is increasingly seen to be key to the continent's development prospects and realization of the MDGs within Africa itself. And I think that the issue is that the point I ended with, there's greater commitment within the continent itself to make sure that you address these issues. where things are working, it's mostly through political leadership, pro-poor health systems, strong family planning programs, and also investments in the status of women. But I think that we can't run away from the fact that there's only a handful of countries we can even call success stories in Africa. The challenge is still quite big, and that the international development community should build on Africa's successes, the success stories, and support efforts, especially to improve universal access to family planning, because there's a huge funding gap. Expand public education on reproductive matters, improve the status of women, and also improve the situation that we are seeing in the urban settings in Africa. Thank you.
What we've decided to do is to take questions after our second speaker speaks, and then we can really have an all-out discussion over an extended period of time, and I'm looking forward to that. I would like to introduce to you next our friend Dr. Jotham Musinguzi from Uganda. He is an obstetrician gynecologist, also a public health physician, and he is the regional director of Partners in Population and Development. Partners in Population and Development is a very interesting organization. It's actually an alliance of ministries of 25 countries, ministries of health, ministries of finance, some other ministries of planning. And these countries, it was started after the Cairo conference, and these ministries actually get together frequently, and they have special meetings and opportunities for the alliances of these groups of the professionals from these countries to be out together and to share ideas among countries in reproductive health and population, and they've worked in a number of areas. Dr. Musinguzi is in charge of the African program, which is huge and has a lot of countries involved, and they have a lot of opportunity to share ideas about what is needed in these countries. He is a lecturer, also a senior lecturer in the Department of OBGYN at Makerere University, and teaches in a number of places too. And he's the former president of the Uganda Medical Association. For a long time, until year 2007, he was the director of the Population Secretariat for Uganda, which is actually housed in the Department of Finance, in the Ministry of Finance. He's on many boards and is a trustee now of the Population Council in New York. So, Dr. Musinguzi?
Thank you very much, Martha. Good afternoon, ladies and gentlemen, and we would like to thank you for coming to be with us this afternoon. I will build on the work that my colleague Eliya has been able to say, and just to remind you that both Eliya and myself, we spend quite a lot of our time trying to engage policymakers on the African continent, be they ministers of finance, ministers of planning, ministers of health, ministers of social development, try and articulate these issues. And I tell you, the terrain that we work in Africa is not easy. These ministers have competing needs. And so sometimes these issues that Eliya is talking about, they are not always finding it easy on the desks of these ministers. And so I will build on the work that he has done and share with you especially something about Uganda. And I also skip some of the slides because basically he has gone through them, but just again to bring out these issues of the statistics. But clearly I think this particular slide is showing you that total fertility rate in Africa remains high, above 5 children per woman, and you can see there the red spot. It is Africa that remains in red. And I think Eliya went through some of these. I don't want to labor them. But just this particular slide shows you that clearly most of our countries, whichever one you look at there, most of them are above 5 children. Whether you look at Burkina Faso, Ghana itself, which is doing well, but still you can see there are problems there. Mali, Niger, Rwanda, which again, Eliya is saying they are starting to show some good signs, but still you can see fertility remains high. Uganda, my own country, and Zambia and others, so those that are here. But this particular slide just telling you that 90% of the countries in sub-Saharan Africa They have TFR, total fertility rate of more than 5, 31 out of 34 countries. Clearly, whereas in most of the regions of the world, more than 2/3 of the women use family planning, in Africa we are seeing on average it is only about a quarter of them. But also say here that 25% of the women in Africa have unmet need. Now, this unmet need, clearly it can no longer be the argument that family planning is being pushed by the Western world, because here is the women who have unmet need, where they want to limit or space. Clearly they are saying we have a need. So it is clearly an indigenous thing, and I think part of the argument that we tell to some of the political leaders in Africa is that this argument can no longer hold. And I want to dwell on economics. Let me go to Uganda and share with you a little bit, because some of the averages mask a lot of things. Just say that less than 20 years ago, the population of Uganda was less than 15 million. It is now over 33 million. It has more than doubled in less than 20 years. And outside there in the corridor, I was talking with a colleague who was in Kenya. He was there when the population was very small, 9 million. He went there later on, it was 19, it had doubled in 20 years. It has doubled yet again. So in our lifetime, we are seeing these things. These are for real. It is not just projections and things like that. We've seen them happening. And again here, you can see clearly that again, total fertility in Uganda is still almost 7 children per woman. And this has implications. So I want to look at some of this in the context of the MDGs, in terms of if Uganda was going to try and achieve its own MDGs. If you look in the year 2005, the population, 2005, the population was 27 million people, and they have children or young people between 5 and 19 who are 11 million. But if you look in 2025, 20 years from then, that group will have more than doubled. These children between 5 and 19, they need schooling, they need health care. So will Uganda be able to have been able to make sure that they have, for children who want to go to school, the classrooms are there, scholastic materials are there, the teachers are there, and those type of things. If you are looking at health care, are the health services going to be there, the nurses, the doctors, the medicines? These are real challenges. And so we've heard about the stories. Some of you are acquainted with Uganda. You know, the president there keeps talking about a big population. Some of you have heard this, that a big population is good. And so we put this to him, and yes, he said, well, in fact, we showed him that in 2050, the population of Uganda will be 103 million. And he said, oh, that is, Uganda is going to be a big country. But the issue was, are you really going to be able to do what it takes? If you look back, in terms of between 2005, if you look at what is the labor force, 15 to 64, jumping from 13 million to 28 million, more than doubling. Are you going to be able to give enough jobs, create enough jobs for all these people in order for you to benefit from the surging population? And I think those are the issues. And I think at that point, even the president of Uganda realized that it is not going to be easy for him. And I think this is part of the advocacy that we must continue to play, the advocacy that we must work with you in all your capacities, the issues that we must deal with, as Eliya was talking about, things that we must take up with the NGOs to be able to work with us to make sure that we are doing the right thing and sending the right messages across. And so clearly for countries which are going to need to address the question of poverty, according to the MDGs, if you are going to look at education, if you are going to look at child mortality, maternal mortality, the question of looking at your numbers, the question of addressing total fertility rate is very important in the African continent. It is also true that we have seen that where contraceptive prevalence it goes up, also maternal mortality tends to go down. And I think these are also benefits that we feel that when we go to ministers of health, I think they tend to listen. This is a soft spot for them. And so this is a part of the type of the advocacy that we continue to move. We also tell them that you realize from this that the poorest tend to have more children, and obviously they have their own reasons why they do this. It is not that it is not a logical thing to do. It is indeed logical. They have their own reasons. Their children tend to die. They need them for labor and those type of things. But we also need to know that there is a need for us to attend to those issues that are making them have too many children. And I think the question of addressing infant mortality rate also becomes important. And so policymakers need to be able to relate with some of these slides. Eliya talked about investing in family planning. This is a familiar slide that shows you that you prevent by investing $1 million in family planning. You can prevent 800 maternal deaths, 11,000 infant deaths, 14,000 under 5 mortality, 150,000 induced abortions, and 360,000 unwanted pregnancies. These are important things because these are women who are dying, women who shouldn't be dying, children are dying, they shouldn't be dying. And I think overall we make a point that if Africa, if Uganda, if Kenya, if Rwanda, and all these countries are going to achieve their MDGs in the context of whether it is education, whether it is health or HIV/AIDS, but also in terms of the environment, clearly the question of addressing the high fertility and making sure that they use family planning is a way that is very useful, and that is part of the discussion that we continue to have. Thank you very much.
As I mentioned up front, we have new friends coming to the center and some old friends. Dr. Malcolm Potts is one who is a recidivist in terms of coming back to the center and speaking, recidivist in the best way possible. He's spoken here about a number of his books before and participated in a range of discussions. And so we're thrilled to, in some ways, ask him to clean up with some reflections in the context of this research that's set in the African context. Also, perhaps share a word or two about a colleague from UNC research who couldn't join us and give us kind of roll us into the Q&A. So, Malcolm, please.
Thank you very much. I'm happy to be a recidivist. I see this meeting as another stage in a multi-stage rocket, the intention of which is to put family planning back on the international agenda. And while we're focused on Africa, many of the themes are generic, and clearly there are significant problems in countries like Pakistan and Afghanistan. So I think it was really Martha who lit this rocket when she helped the British Parliament write a report some of you may have seen called The Return of the Population Growth Factor, which was in what year? 2006?
2007.
Yeah, 2007. In 2009, I helped organize a forum from the Bixby Forum on what the world would look like in 2050. We held that in Berkeley. Jeff Spieler was there, and that was very successful. That led to a publication in this wonderful journal, The Philosophical Transactions of the Royal Society, in London. This is volume 364, because there's been one volume every year since it began. And Darwin and Newton published in this journal, so we feel in very good company. The president of the Royal Society is also, at the present time, the Astronomer Royal, and astronomers can count. And he was so impressed by the contents of this journal that he has set up a working group of the Royal Society, in which Dr. Zulu and I are privileged to be members, which is looking at the big picture of the population of the planet. They will report in 2011. The chairman is Sir John Solstrom, who is a Nobel Prize winner in medicine in 1992, and he's a wonderful person. It's a privilege to work with him. He will be speaking at the AAA, the American Academy of Association for the Advancement of Science, in February in 2011, and I hope that some of you will be able to go to his presentation there. I think already that working group's come to two very important conclusions. One is that the scientific evidence is we cannot bring the whole of the world to the Western level of consumption. I think we knew that. It'd be nice to have it scientifically validated. And also that we've got to stop using GDP as a metric. That we live on a finite planet. We have to find other ways of measuring human welfare. The last day of the Bixby meeting, I now learned, was the first day of the meeting we've just come from in North Carolina, which Bert Peterson organized, which will lead to a theme issue of the Lancet, which will also appear in 211, which will be on family planning, population, and Millennium Development Goals. There'll be a review of the trends. Paul Schutz and David Canning, who are economists, will be writing a paper on economics. And I think one of our needs is to get economists and family planning and development experts all on the same sheet of paper. And I think that is arising. These two very world-class economists are saying both the microeconomics and the macroeconomic analysis is leading to the understanding, which we've already seen from Africa, that growth in human numbers is very relevant to development, and that family planning is not a cost to Ministry of Finance, it is an investment. And USAID does that very well on each of your country things. You have a little bar chart to put this much money in family planning. These are the dollars you save in education, healthcare, etc. And I think that's a message we need to get across. There's also a discussion of climate change and population, and might come up in the question time. Also, there was a very somber discussion in North Carolina of water and agriculture. We learned that it takes 500 years to make an inch of soil. You need 6 inches of soil to grow plants. The West is using topsoil at 13 times the rate at which it's being replaced. And some parts of Asia and Africa are losing it at 40 times the rate it's being replaced. And if you look like a country, Niger, which now has 15 million people, that could well go to 50 million people by 2050, 1/3 of the people already malnourished. There are 213 doctors, there are 19 pharmacists. There's not a snowball's chance in the Sahara of educating people in that society. It's immensely important to make family planning available. And I think the takeaway message of the Lancet theme issue will be that education and family planning are the driving mechanisms of development, that they're synergistic. It's not an either-or option. We need both together. We just heard that very eloquently from Dr. Zulu. And just to add, and with John Cleland, who's probably the premier demographer in England, pointed out at the UNC meeting that of all the biomedical interventions that exist, contraception is the single most powerful. It is the only one that can have an impact on maternal and infant mortality, which is very powerful, on the autonomy of women, on economic progress, on social stability, at the rate at which we destroy the environment. So these are very powerful takeaway messages. But as Dr. Zulu showed from those charts, it's a very urgent message. Waiting 10 years to get family planning back on the international agenda will be enormously costly and possibly lethal to some countries, particularly in the Sahel. So I hope that we've painted a big picture, a picture where there's optimistic stories, and there's also a threat that if people don't act, of very somber outcomes. And perhaps that should be our framework, Jeff, for our discussion and your questions and comments and challenges. Thank you.
Well, thank you very much, Malcolm, for wrapping that together in the larger context, sharing with us the details of this UK Royal Society Working Group, which I do think warrant that attention. It's a tremendous opportunity.
John may speak here, or?
We hope to. I should say that the AAAS meeting that Malcolm referred to is in the middle of February here in Washington, and the plans are in the works for that panel to reprise here at the Wilson Center in the same time period, so that if one is not able to go to the AAAS meeting, we'll still have opportunity and to engage that community in a discussion. So we very much hope that will be possible. So thank you, Malcolm, for bringing that together, and thanks to the whole panel for that rich presentation in terms of data and tying it to both specific place but also specific policy interventions and the intersection of them and how they work together. So why don't we throw the conversation now open to the floor. We have plenty of time for that discussion. As I mentioned before, because we're webcasting it, we want to be sure the folks online can hear your questions, so we'll bring the microphone to you. We ask for your patience in doing that. Who would like to kick off the discussion and get us started this afternoon? Ma'am, down front, Sky will bring you a microphone in just one sec.
Thank you. I'm Barbara Pillsbury. I'm an independent consultant working in the field of family planning for many, many years, and having had the opportunity to work with Malcolm and Martha. And thank you very much for being here, and also to our colleagues from Africa. Now that PEPFAR 2 has happened, and we are no longer laboring under the mandate to not use any AIDS money for family planning, and many now are talking about integration. We've also heard the term smart integration, and I wonder what this panel would recommend in this era where now it is for at least the United States, and of course the United States, as it's operated in PEPFAR 1, had a certain chill effect on countries and on other donors. So that's a positive thing going forward. At the same time, we have the negative factor of the horrible economic recession throughout the world. So thinking about smart integration, how would you see that funds should best be used to achieve the demographic and family planning objectives that you've spoken about in the context of high HIV rates in many countries, and recognizing also that in many countries it's not such a that the HIV rates are very different throughout Africa, and that the contexts are very different.
AIDS is 5% of the global burden of disease, and is taking about 20-25% of the international budget. So I think that it's incredibly difficult allotting money in the international sphere. We're always short of money, but I think it should be based on DALIs and on a couple of years of protection, and that the AIDS money will have to plateau and possibly come down a little bit. I was really the first person to have USAID money in the slowing of HIV in Africa. And I was the first person in, I was the first person out, in the sense that I think there's a certain distortion in international health, the way in which we currently allot money. None of us need to be told how horrible and terrible the AIDS epidemic is. But if you look at the human pain that could arise in the Sahel, as those countries with their very high rates of population growth, as global warming pushes the desert further south, as malnutrition and starvation rise, I think you could have a human suffering in the next 30 years from pain in the Sahel, which is of the same order of magnitude as the human suffering we've seen in relation to HIV. The good news is that family planning works very well, while our ability to slow HIV has been rather disappointing.
Yes,
I don't deal with the AIDS programs directly, but at the country level in Uganda, I know some of what is going on. But I think in principle, and I agree with what Malcolm has said, but also to know that, first of all, we should be aware that HIV/AIDS sometimes doesn't have the same type of controversies that like family planning has. So that is the point that we need to be aware about. Secondly, HIV/AIDS really kills people. They see them, and it has had a very strong advocacy, and a lot of this has been going on countrywide. So the HIV/AIDS community has had a very effective advocacy, and I think this has worked quite well for them. But what I think we need to know is that countries which are poor and get funds like through PEPFAR and any other mechanisms, it is important for them to look for very good ways, and I take the word smart ways of integrating their programs. HIV/AIDS programs and reproductive health and family planning, they use the same clinics, they use the same staffing, and it's, so it makes sense that, especially in low resource countries, like developing countries, that they should really smartly integrate. when we say integrate, doesn't mean that everything can be done in the same way, but I think we need to know they need to do that. But we also need to be aware that obviously treatment for HIV/AIDS remains very expensive, and so the question of putting a lot of emphasis on prevention rather than waiting to start giving drugs to people is quite expensive. Again, in the corridors, I was talking with a colleague, and we are just even wondering how sustainable some of these HIV/AIDS programs are going to be in some of these countries. HIV/AIDS is very heavily supported. So is reproductive health family planning. But big monies for HIV/AIDS. And if this money wasn't available, there would be a lot of problems. So clearly, I think we should say PEPFAR is definitely very welcome and has done a wonderful job in treating people. In my own country, if there is an issue with the PEPFAR, there is a lot of panic because it is supporting a lot of. So we want to really say we welcome the programs, but they should be used in a very integrative way at the country level. And as you know, if some countries don't have so much HIV/AIDS, others do. So they need really to balance their act at the country level. I think the donors themselves should continue to be supportive of that type of move of integration.
Just add quickly, maybe, just to say that I think maybe another useful way in which PEPFAR could contribute more to, the general health issues beyond AIDS is to focus also on strengthening the health systems themselves, as opposed to just being a treatment program. Because if you really have a system sort of approach, which is the integrated approach, I think Dr. Musinguzi was talking about, then you are likely also to address issues to do with family planning and so on. But I think the key issue about AIDS is, when you look at the decline in the resources for family planning over the last 10, 15 years or so, there's been that argument that most of it is going to HIV/AIDS. But yeah, even within Africa, most of West Africa and North Africa, AIDS is not such a big issue. But I think if you also try to generalize and try to say, to look at it from a general perspective, then you have to see at the situation in Southern Africa, Swaziland, Zimbabwe, South Africa itself, if you're having your 30% of your adult population, 35% infected, then it becomes a very, very critical sort of issue. So I think we have to look at the specific country issues, but more generally have a more systems approach to addressing the health issues and get away from the vertical programs as much as possible.
Okay. The gentleman here, and then right here.
Hi, I'm Allan Johnston. I'm a visiting fellow at the Population Reference Bureau. In my training that I do, a lot on advocacy training, I tell people that what we have to do is to understand the opposition. And I think maybe as a group, we've tended to underestimate the strength of the opposition here. I like Malcolm's comment that we have to somehow get the economists and the family planning together. I've worked a lot of my career in Kenya, and when I looked at the most recent National Vision 2030, I was astounded that there was no mention at all of rapid population growth or of high fertility or of family planning. It just wasn't there. So I've done a systematic survey of talking to the lead economists in Kenya. I've talked to many, many of them. Many of them are trained at Strathmore, which is a Catholic institution in Kenya. But some are trained at Harvard University, and it didn't really matter which one it was. They all were completely convinced that development is the best contraceptive, and they had been systematically sort of brainwashed to say that family planning is not something we can intervene. There seemed to be universal opposition to that in Kenya, to the point where we haven't heard one senior economist or senior family planning person or senior member of the government say the word family planning. Until recently, the Minister for Planning has said it. Now, he's one person out of 40 or 50 that I've talked to. But I think that we need to really understand maybe our opposition more, and as part of our broad advocacy, think through, why is it that Eliya's data, which is so convincing to me, why isn't it convincing to all the people who are allocating resources in Africa?
Eliya, can we have you start with?
I think that's basically the big challenge that we have to deal with, and I think Jotham's organization, our own organization, is focusing on those issues. How do you get those critical audiences actually understand that, as Malcolm said, that this is an investment? I think a lot of people look at health as what? Not as an investment, as some sort of a consumption, sort of a expenditure. So when you look at family planning is also linked to the whole broader spectrum of sexuality, and a lot of leaders in Africa, don't want to get involved in that sort of issue. They tend to think that it's a personal matter. People are deciding whether to be sexually involved or not, and how to protect themselves and so on. But I think that the evidence that I showed there to demonstrate that there's a big change on the continent now. I think Allan, about the big conference that took place in Kenya. It was called the National Population Leaders Conference about 2-3 weeks ago, where Kenya has realized that they made a lot of progress in addressing population challenges, increasing contraceptive use, but that there was a stall because the program was not as energized as it used to be. So now there's a new sort of effort in Kenya to say, let's get back to our to the steam that we had before. So the Minister of Finance, I think Kenya is a very, very good example. As you know, despite being one of the successful countries, despite being one of the pioneer countries in reducing fertility in Africa, the first time that Kenya actually put contraceptive commodities in their national budget was in 2007. So all along, the issue of family planning was seen as a Western issue. So countries like Kenya that were receptive to the idea provided the enabling environment, but they didn't want to put any of their money on it. And part of the work we are doing in Africa now is to say, if you think this is important, put a bit of your, scarce resources onto family planning. And that is happening. In Uganda, we just learned this year the president, despite opposing the population growth sort of explanation for a long time, he just asked the Minister of Finance to put $3.4 million into the national budget for family planning. In Kenya, there's a push now to increase the allocations that are there. So, I can understand your frustrations, but I think the landscape is changing, and we need to build on that.
There's right next to... There's a question, then we'll come right down here. We'll get just the three of you together.
Well, my question, Hazel Denton. I teach a course on population and development at Johns Hopkins and Georgetown, which is exactly a follow-on to ask Dr. Musinguzi about Uganda. And so what you've just said about the fact that finally family planning is in the budget is very important. The thing is, looking at Uganda's TFR, it's high, very high. It's between 6 and 7, and it's been there for years. And yet we tend to sit here and say they just don't have the information. They don't understand the implications. You meet with the president, you show him the numbers, and he thinks it's great that the population is growing. How does one get over this issue? I remember once I was working with Nigeria on their population policy, and I gave a speech, and I was trying to get everybody revved up. And so I said, in a tone of horror, do you realize that 1 in 4 people in sub-Saharan Africa is a Nigerian? And they didn't say, oh, they burst into applause. So I would love to hear how one can somehow get that dialogue going in Uganda.
Yeah, well, thank you, Hazel, for that very important question. Of course, Eliya has also hinted about some changing situation. Terrain in Uganda, after a long time, I headed the population program in Uganda for the last 15 years. I retired before I could convince the president about this issue. But recently, we also decided to intensify our advocacy efforts working with some other people. And so we are seeing, he has agreed that he will put money into family planning for bus spacing. He clearly said to the Minister of Finance, bus spacing. That is his comment. That's how he says he will support family planning for bus spacing. And he even said it at the UN during the high-level meeting recently on MDGs in September. I was with him in New York, and we made sure we asked him whether we can put in his speech, and he said yes, and he said it that way. But he didn't say it the way we wanted, but he said it for bus spacing. That's what he said. But we think that's a good point. But the point I think we are making here is that the terrain, there is a change in Africa which is going on. It is coming on slowly. It is not enough. It is not in as many countries as we would like. But we think the efforts of various partners, and it is not just our two institutions, but clearly a number of others, USAID, UNFPA, GTZ, and DFID, a number of donors and NGOs, including NGOs, both local and international, other institutions. I think the momentum is being built. We would like to see more economists being supportive of these efforts and lending their explanations which can be helpful. We haven't been very successful with the economists in this particular area, and I think together we can make a difference, and I think that's the way. It is not easy, as we've heard. Some of these are, people's backgrounds. If you are a general, I'm told a military general, your liking numbers is likely to be probably more than other ordinary people and those type of things. But also we have people who have conservative views in Africa, and there are those who still look at this as a foreign thing. And then there are those who look at it as being controversial. They don't want to touch it. Some of it, they think if they support family planning programs, they may not get the Catholic vote. So there are a number of factors there, and so we need to be aware. But these are the efforts that we must continue. But as I think we have said with Eliya, the time is now. We need to push it further, do better, have better arguments, but continue the work and keep there until the work is done.
Can I just add quickly on the issue about Uganda? Actually, one thing that I found very interesting is that the argument, the framing of the issue, I think, as Allan said, the framing of the issue needs to change in line with the sort of opposition you are dealing with. So in Uganda, it was very clear. Every stakeholder you talk to there, people will say the issue about convincing the government to do something on the basis of rapid population growth was getting us nowhere. So now the stakeholders there have started emphasizing a lot on the MDGs, the health-related MDGs. The link between family planning, maternal and child health. That's why when the president came in, that's the argument he's using. He's talking about child spacing, which is bound to improve maternal and child health. But another critical thing that the Ugandans did, and which appears now to have also convinced the economists that this is an important issue, is framing the question on looking at the population as a resource, as an advantage. So they are focusing on this demographic dividend issue. That, the population is big, yes, the population is growing fast, but if we even make it drop faster, we're going to have this youth budge, and if we invest in the quality of this population, that's what might actually propel Uganda to the middle income status country, which is what Uganda has stated, as well as Kenya, in their visions 2030 and 2040. So they are looking at the Asian tigers and saying, oh, in the 60s, we're more or less at the same level with Thailand and all these countries. What happened? And they get this piece that part of it was the dividend. So people are now beginning to look at the population as a resource, but you can only achieve that if you reduce it first, and then you get that bonus that can propel you to further growth.
Okay, there's a hand all the way in the back, and then we'll go to Roger Mark in the middle.
It seems like we've focused a lot about a lot of leaders being proud of the population growth and looking at, getting a positive dividend out of it. Do any countries recognize the problems? Has there been any talk of anything remotely, obviously not as extreme as China's one-child policy, but anything of that sort? Or is it strictly in terms of population growth and potentially improving the opportunities? Or is anybody talking about the trying to reduce actually the population growth?
I'd like to take that sort of sideways, combining that also with the comment about the behavior of the economists, or the attitudes and thinking of the economists that were mentioned. I think there are a couple of things going on here. I see that there are two big questions about population. Is population growth a problem? And if so, then what does one do about it? And I find that if people, because of that language that was used by some of the economists, that we cannot intervene in family planning, that implies that they're worried that we're telling people what to do. Your word opportunity is perfect in your question, that we think that what really brings down birth rates is the ability of women in particular to have the opportunity to manage whether and when to have a child. We insist that family planning is not about telling people what to do, it's letting them have options. When I was in the Packard Foundation, as soon as I joined the Packard Foundation in the early 1990s, I decreed, if you will, that we shall not use the words promotion or motivation or behavior change. If I were a poor woman in any of these countries, I would be really offended if people talked to me about, we're going to motivate you or watch your behavior change. But this is about letting women have options. And if, in fact, the economists are uncomfortable about intervening in family planning, it seems to me it's about letting people have the opportunity. They also have some theory problems that the unmet need language doesn't fit microeconomic theory. And that's something we struggle over, and we need to work better with language in which we can explain these things in their language, economist language, and actually to translate the opportunity part to the economists. That we don't do that well yet. We're trying.
Okay, Roger Mark, and then we'll keep working that side.
Thanks very much, and thanks for your very insightful presentations. I'm Roger Mark D'Souza with Population Action International. And just last night, I returned from Cancun for the climate change negotiations, where we were having a series of meetings within the civil society forum linking these issues that we're talking about today with climate change adaptation. And I wondered if I could ask you to comment a little bit about what are some of the best ways to make that linkage for key policymakers in Africa, and how that message might differ for specific regions within Africa, as you were mentioning, Dr. Zulu, for Eastern Africa, Middle Africa, and Western Africa. So how can that message be nuanced for different sub-regions within Africa?
I think, fortunately, again, we just came from University of North Carolina, where this issue was on the table. And by and large, I think what we sort of agreed on is that in the cases of Africa, when we are talking about some of these changes, rather than talking about climate change, we would rather talk about the impact of populations on the environment. It makes a lot more sense to them that way. And I think a number of countries in Africa, if you started telling them that they are contributing to climate change, they will first ask you to go and give that message to the United States and China, and not that they are not contributing, but I think their contribution is really small. So I think it would be the way we are struggling with these issues. If I had to go and again start engaging the president of Uganda that we also want you to use people to use family planning because Ugandans are contributing to climate change, he will be laughing at me.
Right.
But we can also tell him that you need to know that your people, because there is the increase in the people, they are encroaching on the wetlands, on the environment, those type of things, and those make a lot of sense to him. He is seeing that the acreage of land for people to grow their food, because in those types of countries like Uganda and East Africa and Southern Africa, it is a smallholder type of thing. Your acreage is becoming smaller and smaller, and we have traditions of passing on, dividing land between sons and those type of things. So those type of things that where we can come from. So I agree that we should continue to be engaged in this, but issues of more of adaptation than really issues of climate change, I think that's what. And fortunately, this was a discussion that I think we sort of had some concurrence on along the line. Clearly, there is a message for these countries as well on issues of environment.
I think just to add very, very quickly on that, the differences across the various regions in Africa, my sense is that the countries where the biodiversity is threatened more. I mean, you look at the countries in the Sahel region, even the Horn of Africa, the actual Horn itself. Those places are extremely fragile, and the environments are extremely fragile. And when you talk to them about the need to actually address the rapid population growth factor as a way of enhancing their capacity to adapt, that the message is going to resonate much more strongly with them than maybe places where, you know, they have enough land and they have enough rainfall and they are not yet hit, you know, by the environmental sort of problems that the continent is facing.
The developing world produces 3% of the carbon output. We're the problem. I'd just like to quote one finding from California. We have a federally funded program called Family Pact, which offers family planning really on a sort of output-based assistance, incentivizing providers for people at 200% of the poverty level. That program has been very carefully evaluated by Claire Brindis. In 2008, it prevented 123,000 unintended pregnancies. Those pregnancies would have led to a birth that on average would have lived for 77.8 years. For every year those people were alive, they'd have put out 19 tons of carbon. And in fact, we know the costs of this program very well, and the single most cost-effective way of reducing carbon output in the North is family planning. It is an order of magnitude more cost-effective than windmills or solar power. The figures that I think are at the right order of magnitude, my calculation of family planning was about $8 per ton of carbon, not produced. Windmills, I think, are $23. Solar panels are something like $50. Electric vehicles are $131. Half the pregnancies in the United States of America are unintended. Think what we can do for that wedge in the global warming problem simply by improving voluntary family planning in the North. One more thing. For the economists, really the senior, most respected economist in Great Britain is Lord Adair Turner. He is chairman of the Financial Services Commission, which doesn't really have a parallel in the United States, but it's rather like being chairman of the Federal Reserve Board. He has a great article in this publication of the Royal Society, just making the case of how, as really the most respected economist in Great Britain, saying how important family planning is. I think that and the paper that Schultz and Canning will put in the Lancet will provide the documentation that we need to bring economists around.
Gentleman right there, and then we'll move across. Thanks.
My name's Ray Martin. I'm with an organization called Christian Connections for International Health. It's a network of 165 organizations plus individuals involved in promoting international health from a Christian perspective. Somebody mentioned knowing your opposition. With some help from USAID, CCIH conducted a survey of our members. Martha, in fact, was involved in the early stages of that a bit. And we found that if one positions family planning appropriately, all the Christian organizations in our network are actually pro-family planning. Now, it's very important to use the right kind of language. But with that encouraging, I have a couple copies of the report if any of you are interested. With that encouraging finding, we dared to be fairly proactive in working to promote family planning with the U.S. Congress. And we had a couple grants, one from the UN Foundation, to help us do that, and collaborated with a number of other advocacy organizations. And we had some success because we were able to reach some of the conservative members of Congress that some of the other advocacy organizations have more difficulty reaching. We've recently had a discussion with some of our friends about the new U.S. Congress that will be taking office in January. And I think everybody, with respect to family planning and the hope for increase in U.S. commitment and funding for family planning, sees only gloom and doom. And so I'm wondering whether any of you have thoughts about messages that we might use, all of us involved with the U.S. Congress, but certainly an organization like mine, which has access to some of the more conservative members. How do we reach them? And for our two brothers from Africa, can I appeal that you would be very proactive in trying to work with us to convey the message to these new legislators that Africa does want more assistance for family planning or birth spacing or whatever you call it? How do we strategize now, given the new profile of the next Congress?
I am very glad to hear about the work, the wonderful work we are doing, and I think we are partners in this. Just say that about a year ago, I did indeed come to, I came to work with some people to reach out to some Congress people here to try and put the case why the United States should continue investing in family planning and reproductive health programs. And so the point that I think we can make is that I assume that, of course, Eliya would also want to continue to be engaged on these matters. But to say that I think in part of the work that we need to do, we need to make sure that the continent itself is preparing itself to say, yes, we are serious about these programs. We care about our women and children. We think family planning is useful, is important. And I think if they can continue to put more money there, they make the policies, and our colleague Allan was talking about the Kenyan vision. Clearly, I think we had some mixed messages. Our own development programs at a national level need to reflect these issues, that we think they are priorities, and therefore we are going to put money there. But we're also mindful that even if Uganda wanted to fund its family planning, it could, of course, do it. But it would be at the expense of other things. We have talked about their resource envelope is very small for the economy. These are economies which are still small. They are fragile. Sometimes they have emergencies of floods, of wars, of civil strife. So sometimes they shift resources from what we planned for to those type of emergencies. But we are also talking about not so much resources. So there is a need for country ownership, country taking, making sure this is an area of priority, and I think that is our leaders should pronounce themselves on that first. Secondly, after that, they should come together with us to be able to make the case, whether to the Congress or wherever it is necessary. But clearly also at the international meetings, some of these African leaders are invited to the G8, to the G20. They represent Africa on this. They are at African Union summits and those type of things. You'll be pleased to know that in July this year, in Kampala, Uganda, there was the African Union Summit where all the presidents came. It was in Kampala. And the subject there, the theme of the summit of the heads of states of Africa for this year was maternal and child health in the development of Africa. So again, as we said, things are changing, but we need to continue moving on, and I can tell you that for us, we are committed to continue to advocate for these issues, and we are willing to do what it takes to come here and engage those who need to be engaged, working with all of you. But we also want to make sure that the message is coming from the leaders in Africa, and clearly the issue of saying that family planning is a foreign thing, we see that unmet need is showing women need this. They are the ones asking for it. So the leaders who are elected by these people need to do the right things themselves. So I think that is our message.
Okay. Gentleman at the end, and then we'll come to Jack. Oh, sorry, we got another one over there too.
Robert Schroeder, international investor. I'll be brief and blunt. I got here late. I appreciate everything that all of you are doing on this panel, but I wonder if we need to be a little bit bolder in our thinking. Right here in Washington, you don't have to go to Uganda or Kenya to see this problem. We have serious opposition right here. The World Bank no longer really puts this on its agenda. The United States government removes this discussion in every way, shape, and form. Politicians won't touch this subject. We've got a lot of reasons for it, religious and otherwise. I won't go into all those now. But the point is, this has been largely removed from discussion here in Washington. The Washington consensus no longer wants to really deal with this issue. Even in the country reports from the World Bank, you just get polite mention that rising populations contribute to some problems here and there. Nobody wants to really address them. So my real question is, when I hear you say we have to convince more economists, again, let me try to be polite here. Who in the world cares what economists think? We've got 1,000 of them at the World Bank that have been saying this for a long, long time. They're pushed to the side. We really have to think bolder if we're going to start gaining any momentum for these issues, at least in the Washington side of this. So for those of us who want to try to raise this issue, I just think we all need to think in more practical terms and more political terms of how we can move these ahead. Thanks.
I think that there's a very, very big window of opportunity with the international focus on MDGs 4 and 5. I think, as Jotham was saying, the African Union is making maternal and child health, the theme of the conference and so on. So I think the health issue, I don't know, whether economists also oppose actually investing in women's health and children's health and so on. The issue about population control can be divisive. I think the numbers I was showing here, some people look at them, some people say, as Dr. Musinguzi said, oh, we are doing well, our numbers are growing. The issue about Nigerians bragging that out of every 4 Africans, there's one Nigeria. So people can come from all sorts of angles to argue, and sometimes for very, very justifiable reasons why having a big population might be a good thing. So I think that the point is that we shouldn't drop the ball on that, because that's still very, very critical. I think that the policymakers have to be more strategic in their thinking. The numbers I was showing, like Ethiopia growing to 300 million people, when the country is struggling so much to take care of 95 million, the policymakers shouldn't just be thinking about the next 5 years. They should think about where the country needs to be 30, 40, 50 years from now, and think about the consequences of the decisions they are making now. So I think we can't leave out that aspect. But at the same time, understand that different constituencies in this argument are looking at the issues from different angles. And I think the health angle, I told you about banning of family planning in Malawi in 1969. The argument that got the president there to approve family planning again was the child spacing argument. That, this will improve women's health and so on. He approved it. So over time, I think as we are thinking about meeting this huge unmet need for family planning, there will be greater conversion also to family limitation. So I would think that in cases where people are extremely conservative, let's focus maybe on the health effects of family planning, because it's very, very hard to find people who look at the high rates of maternal mortality, the high rates of child mortality, and oppose putting family planning in those programs, because it has such a huge impact in reducing the vulnerability of women.
Thank you, Eliya. I think that's good. Just to you are very blunt, and I think you are right. Who cares about economists? But agreed. But these economists also won at the World Bank. In most of the programs in our countries, if we want things put in the PRSPs, you need to engage the economists, the World Bank. I know they have not been very forthcoming, but we haven't given up on them, so we are still working. In our countries in Africa, most of the ministers of finance are normal economists. If they are not economists, the whole bureaucracy just below them, permanent secretary, director general, they are all economists. So they need to be engaged. They are the ones who move money in the budgets and whatnot. And we clearly still see the countries are not putting the right budget. So we think that if they were convinced and the ministries of health people came and said, please finance Putin, we think it could work. We've been at it. We haven't succeeded yet. But that is part of the reason really why we want to engage economists.
Mm. Yeah, you'll have to tell us how the session you're doing at the World Bank tomorrow goes in terms of the reception.
Right, tomorrow actually we are going to World Bank.
Yeah, that's right. Jack Goldstone down here, and then we'll go right back over there next.
Hi, I'm Jack Goldstone from George Mason University. I have to say this argument with economists is not one that you'll win. Your colleague, Ron Lee at UC Berkeley, did a report for the National Academy of Science some years ago showing there's very little correlation between population growth and economic growth rates. I can point to Ethiopia and Malawi, who are growing at 10% last year. I can point to Japan and Iran, the two most successful countries in reducing fertility, who have been mired in economic slumps. The reasons for economic growth tend to be much more corruption, lack of good governance, conflict, diversion of money away from education to military spending. These are the things that economists will tell you they must focus on, and I agree. So what can you say? I think one of the most important details that you slid by in your presentation was the stalling of the demographic transition. One of the reasons economists and others are not exercised about population growth right now is that the current UN demographic projections show population growth in the world ending at 2050. These are fairly reassuring projections for those who don't want to worry about this. Those are the medium variant ones that assume fertility will decline. So it's important to say there are a number of places where the fertility decline seems to have stalled, and at current fertility rates, if they do not go down, we will be looking at 1 billion people in Uganda in 120 years, and no one thinks that that can happen or be a good thing. So it's the stalling of fertility decline that needs to be addressed. Then, in addition, by the way, you can tell people, if you want to address maternal mortality and infant mortality, this is one of the cheapest ways to do this. And I think there's also an important lever that needs to be pried with all of those public health foundations and agencies that are working hard to address malaria and meningitis and that are aiming mainly at reducing child mortality. If they are successful in doing that without a parallel investment in making family planning more available, they will worsen the difficulty of producing educated, high-quality, rich job potential young people. They don't want to do that. So asking them to divert a little bit to match their success in one area with success in another, I think may be helpful.
Thank you, Jack. Martha, you want to respond?
Yes, that's excellent. And I do find that there's something that they're missing. They're missing the concept of necessary versus sufficient. No, family planning is not sufficient for achieving everything in development, but it is necessary. And as I said in the very beginning of this meeting, we've recognized we can't find a country that is developing or getting out of poverty while maintaining high fertility or high birth rates. And economists have come to me and they said, okay, where are your numbers? And I say, well, our number is 0 because we can't find one. And they laugh, but then they say, and they recognize that, if you can't find one, that's a clue somewhere along the way. But if we hold on to the necessary and sufficient distinction here in talking about family planning, what happens if you don't have family planning? You can't achieve any of these other things. You cannot, we can't find countries that with very high fertility, they're able to expand their education. Education is very important. It's even important for fertility decline. But if a country has very high birth rates, then their education systems can't grow fast enough to catch up with the fact that there are many more children born each year than the year before. And I think turning this into a clearer picture, I think, might help. And thank you.
Let me give you one statistic from outside Africa. Greg Mortenson's 3 Cups of Tea has been in the New York Times for many weeks, and he's a wonderful person. And I think he's built 131 schools that have 56,000 pupils, a lot of them girls. And that's a fantastic achievement. He certainly understands very, very difficult tribal behaviors in Pakistan and Afghanistan. But Pakistan and Afghanistan together have 11,000 more pupils every day than the day before. So his achievement is 1 week's growth in the number of children wanting education. And most people who read the book don't have a sense of scale and they don't understand those numbers. If we can get those numbers across in a respectful way, while enormously welcoming those kind of achievements, and nothing seems to, I think all of us in this room would agree, nothing is more important than education except female education. I mean, that should be our number one, should be our priority, but it has to be linked with family planning. These are the drivers of development.
You haven't been very patient right there, in the green.
Hi, my name is Ellen Smith from Futures Group. I have a question about the time horizon of talking about all of these family planning arguments about investing in family planning versus spending money in family planning. We've seen some background figures here about the next 30, 40, 50 years. And we've heard about how important it is to look at family planning and investment that will save you money in other sectors. But many politicians, as we know, have a much shorter time horizon than that. So what would you advise as far as some near-term advocacy for family planning? A lot of the cost-benefit analysis that we typically do requires some time to take effect. So in the next 1, 2, 3, 4, 5 years, you see savings in maternal health, neonatal health, but not in a lot of these other sectors. It takes time for children from birth to high school. So especially as we are dealing in the context of other sectors, such as HIV, where you can see effects immediately if someone contracts HIV or not, if someone is treated with HIV or not. That makes a difference if they'll be sick next year. With family planning and population factors, we don't have this sort of immediate impact. So what would you advise as far as near-term advocacy with policymakers?
Yeah, actually that's one of the challenges, and I think one would hope that by demonstrating this sort of numbers, seeing what will happen 20, 30 years from now, that you are going to get policymakers to shift a little bit from their short-term sort of 1 year or 5 year planning or strategic planning and so on, to start thinking about where the country is going in future. A friend of mine commented that what they see as a big difference between, say, policymakers or leadership in Africa versus, say, in a lot of Asian countries is that strategic thinking about where should the country be 20, 30 years from now. So I think on the one hand, we need to captivate that. We need to make sure that there's that shift. But I also share your frustration to say that how do you get them then to see the agency of the problem? So my advice to that would be just to say we need to do both. That emphasize the things that they will see as having short-term impacts, like maternal health. If you invest in family planning, you don't have to wait for 20 years to see what impact it's going to have. I think people are seeing the land being subdivided. Jotham was talking about that. You pass on the land to your children and so on. Your children will have to pass on the same land. Those are things that people can see within a few years' time. So we have to do that, but I think getting people to think more strategically about the future is what will get us to start investing more aggressively in the quality of the population. It's scandalous in my view. You look at some of the statistics. Look at Burkina Faso, for instance. We did a survey in Burkina Faso in 2004, 2005 among young people aged 12 to 19. Among girls aged 12 to 19, 60% had never been to school. I mean, I don't know whether what it means to look at short term, but really a country can't think about developing, can't think about escaping poverty if you can't think about the long-term impacts of having a population that is that doesn't have the skill base to propel the country forward. So I think we need to focus on both aspects here.
Right, and clearly there are issues. Part of the work that we've done with the political leaders in Africa is to, in the work that we do, we also show them the benefits of clearly family planning has immediate, very short-term benefits as well in terms of maternal and child health. That's one, as he has said. But you also tell them that there are reasons why you must be visionary. As a leader, you are not just a leader for today, and you have a responsibility. And a leader, you are elected, it is a responsibility to make sure that you are also putting in place these long-term issues and plans. It is your responsibility. That's why you're a leader, that's why you're elected. So we know what you are really saying is very important, and it may also be actually one of the reasons why we don't succeed so much. It's part of the situation, but I think it is our responsibility to remind them about possible short-term successes during their time, but also laying a foundation for the future of their own countries along the line.
There's a question on the wall there. Maybe our last one.
Thank you. I'm Gary Steele with JSI, the Deliver Project. A little glimmer of hope I've seen over the last decade is that when you go to various ministries of health, you see more and more women in roles of leadership. And you know that these women, because they're highly educated, have a much lower total fertility rate than their sisters across the country. My observation, this is very anecdotal, is that they tend to be excellent networkers. And so we might hope that by encouraging leadership roles for more women in these areas, that they will become champions, movers and shakers, whatever the current buzzword is. So please, let's try to remember that when we think of anything from scholarships to whatever, trips to the States, whatever. But my real question is a very brief one. Are we fairly satisfied with the range of contraceptive options we have now in the contraceptive technology? Or is there looming on the horizon someplace in the Guttmacher Institute or something, even better contraceptive that is not supply-based? I work in contraceptive supplies and contraceptive security. Are we looking 5 years from now about something that we don't even know what it is that would really help us with this? Thank you.
Right. Let me talk about the issue of champions, and I think either Eliya or Malcolm may talk about the range of methods available. The issue of champions in the region, this is part of the work that we do with Eliya. We go out there and identify champions. We have some criteria of who they tend to be women, but some of them are men as well. But we have women champions that we are working on. We go to different countries and identify them. We build capacities for them, sort of some, I don't want to call it training, but we have things that we expose them to so that they have a better understanding of the linkages between these issues we're talking about and development along the line. So that they are able to speak about them more confidently. They get convinced to see what it means. So we build that type of confidence for them. We give them skills. We also give them some skills of how they can speak out on these issues, how can they use the data and the figures and to speak out. But we also identify opportunities for them to go. For example, if we find there is a meeting here in DC and maybe there is a need for a voice of either a woman or a voice from the South, as we say, from developing countries, or around the meetings of the G8 or G20, we tend to facilitate them to be able to go there, and if they need information to go and use, we also prepare it for them, with them or for them, so that they can use it and be able to speak out clearly, so that they bring to the donors and to other groups the voice of the woman from Africa, from a developing country. So we are doing that, and I think that's an important perspective.
I think maybe I'll let Malcolm talk about the technical aspects of contraceptives, the options that are there, and so on. But just to comment on basically giving choices to people in the field or at grassroots level, I think one of the big problems we face is that a lot of the programs actually have one or two or three sort of options, and the end result is that if it doesn't fit the woman, I mean, you look at Africa at the beginning of family planning programs, most women were using contraceptive pills, but there's been a big shift towards injectables and then more long-term methods. Part of it is the convenience for the women, convenience for the providers themselves, because it reduces their workload and so on. You're not seeing the woman every month. But I think there's a big issue there relating to the choices that people have, because one of the main reasons why people discontinue using contraception, apart from wanting to have another pregnancy, that is because they think that the method they are using is not appropriate for them, and then they don't have another option within the clinic. So I think the issue about diversifying method choice for women and overall in the programs is a very, very critical quality of care issue that needs to be looked at. But I don't know in terms of the industry, what's happening in terms of expanding the options that are there.
I spent a large part of my life trying to make bigger and better contraceptives. I'm absolutely certain you're not going to get any sudden surprises in this field. It is a very slow, extremely expensive process introducing new method of contraception. I think we'll still be using hormonal methods in 2050 and in the 22nd century. this year, and the information doesn't seem to have got around in groups like this, who's aware of the studies that came out of Great Britain earlier in the year on the long-term follow-up of the pill? Now, isn't that astonishing? One person. In 1968, the Britain started with 23,000 pill users and 23,000 controls. We have followed those women for 39 years. There's another parallel study of 17,000 people. Altogether, we have 2 million women years of observation on oral contraceptives. There's no other drug that comes anywhere near that in depth and extent of knowledge. Those studies show that women who take the pill live longer than women who don't. The relative risk of death is 0.88. Part of that is that we selected out smokers, but a significant part is great reduction in ovarian and uterine cancer, bowel cancer, melanomas for some reason I don't know, but I welcome. And there are effects that last for these women haven't been taking the pill for 30 years, they probably took it for 2 or 3 years. It's enormously convincing data. And heart disease over a lifetime goes down if you took the pill. I mean, these are astonishing findings, and they're absolutely robust, and they apply to all women around the world. That I would say with total conviction. We all have the same pattern of hormones, we all have the same uterine lining, we all make the same eggs. So, you know, I've always said that any new contraceptives, particularly if it's hormonal or doing something big to the human body, is an experiment on our own species. I will give to my loved ones things that have been around for a generation. What we need are large numbers of generic low-cost pills. This is where South-South cooperation comes in. Family Health International is introducing the Sino implant, a low-cost, long-acting contraceptive that comes out of Shanghai. They're getting that registered in various countries. China has begun to donate contraceptives to Africa. India could do the same thing. Korea could do the same thing. You know, when I entered this field, it was the North saying there's a problem with population growth. Now it is the South that is ahead and saying these are things that we want. This is how we're helping one another. South-South cooperation become more important. But we in the North can't drop out of the system. We need to make partnerships. And this is why it's so exciting having Jotham beside me, who represents Partners in Population Development.
Malcolm, can you give us the reference? Was it BMI or Lancet?
The Lancet article was by a man called Hannaford.
BMJ.
Was it the BMJ? And the other one was by Martin Vesey, is a 17,000.
I'd like to add something. That was in March, the BMJ. I would like to add something about the women as champions and women as communicators. I think that women's groups are a huge opportunity around the world. They can be powerful and they can work on their own. I want to put out a word of caution for integrating family planning and AIDS in a lot of situations. It's very helpful in certain situations, but what you really, really need to do is make sure that the family planning is not dependent on clinics, that family planning should be able to be in the hands of women, of people who are not doctors, not nurses, not midwives, and be able to have the power to let other women have the ability to make decisions about their childbearing. Lots of family planning methods are so safe that they do not need a medical or clinical environment at all. We've talked a lot and we've done a lot of research on the barriers, or really reviews on the many barriers to contraception around the world. And the barriers include lots of rules that make it impossible for non-medical people to get out family planning. I think family planning belongs in the homes, in the hands of women to manage through other women, through much of the world. Thank you.
Terrific. Well, I think we've come to the end of a period, a very rich discussion, both in the presentations and some excellent questions. It's a really successful meeting for us when we have conversations both with scholars and practitioners who are not based here in Washington, as I said, kind of talking among ourselves in D.C., but really bring in the insights from colleagues around the world, and I think we've done that today. And so please won't you join me in thanking our panel, and then we can continue the conversation with a reception right outside.